Good evening, everyone. Welcome to this evening's webinar. Tonight, we are presenting Diabetes Remission and Obesity Management, Effective Clinical Approach with VLCD. My name is Dr. Lee Fong Ching from SASO, and together with me on tonight's webinar are my co-chairs, Dr. Verena Tan, representing SNDA, and Dr. Bob Ling Yong from OMSSS. Thank you for taking time out and being here today. So just a few housekeeping announcements before we get started. If you have any questions during the presentation, please type them into the Q&A tab in the control panel and we'll discuss them at the end of the talks. Next slide, please. So here's the agenda for tonight's meeting. In this webinar, our two expert speakers, Dr. Amy Rothbery and Ms. Hedy Cheng, will share their clinical experience on very low calorie diets, or VLCD. First, Dr. Rothbery will discuss the use of VLCD in diabetes remission and obesity management. Then Ms. Hedy Cheng will talk about the use of VLCD in weight management and bariatric patients. This will be followed by a Q&A session to discuss any questions that you may have for the speakers before we close the meeting. Next slide. Now, without further ado, I'd like to introduce our first speaker for tonight, Dr. Amy Rothbery. Dr. Rothbery is an associate professor in the Division of Metabolism Endocrinology and Diabetes and associate professor of nutritional sciences in the School of Public Health at the University of Michigan. She's the director of the University of Michigan Weight Management Program, highly successful clinical research program in which patients with moderate to severe obesity undergo an intensive lifestyle intervention resulting in profound weight loss and improvement in cardiometabolic and other obesity-related health conditions. She'll be sharing her clinical expertise on the use of VLCD in diabetes remission and obesity management. I think many of us will be very excited to learn more about how we can effectively use VLCD for our patients and add it to our armamentarium to treat type 2 diabetes. Over to you, Dr. Rothbery.
Thank you very much, Dr. Lee, and I'd like to thank all the organizers and moderators, specifically Nestle, the Singapore Association for the Study of Obesity, the Singapore Nutrition and Dietetics Association, and Obesity and Metabolic Surgery Society of Singapore. And welcome to all the participants. It's good evening to you, but it's good morning to me. So these are my disclosures. And I hope today that I will familiarize, or you'll familiarize yourself with the concept and approach of, I'm sorry, I'm going to need to turn this off for a minute, of lifestyle interventions incorporating total diet meal replacement. And I'll refer to this now as TMR and help you understand how to apply TMR in patients with multiple comorbidities, and also further consider the role of TMR as a strategy for weight loss and for resolving some clinical comorbidities. So as we know, obesity has far-ranging economic implications that include excess sick leave, loss of productivity, and also excess healthcare costs. The direct medical costs related to obesity, at least in the United States, are $210 billion annually and continue to increase. The costs for individuals with obesity are 15 times higher than the total cost of overweight individuals, irrespective of gender and employment status. And our Centers for Disease Control, or Epidemiology and Public Health Organization, estimates that 1 in 3 adults could have diabetes by 2050, the majority of which is preventable with weight loss interventions. And weight loss interventions, it turns out, are very cost effective, as little as $830 to just over 12,000 quality adjusted life year gained. The benchmark for qualities is hemodialysis at 50,000 quality adjusted life year gained. Excuse me while I remove this bar. A sustained 10% reduction in body weight would decrease expected lifetime medical care costs of high blood pressure, high cholesterol, type 2 diabetes, heart disease, and stroke by $2,200 to $5,300 for women and men. So weight loss, as we all know, requires an energy deficit usually achieved by reducing the amount of calories consumed in a food-based diet. And food-based diets typically average about 4 to 8% loss of initial body weight. Total meal replacement is the use of meal replacements as the only source of daily nutrition. And in general, they can be delivered as very low calorie diets when below 800 kilocalories per day, and as low calorie diets when between 800 and 1200 calories per day. But they can also be used at higher calorie levels, either as total or partial meal replacement in calorie restricted diets, which really typically range between 1200 and 1800 calories per day, depending on whether you are a woman or a man. So, a luminary in our field of obesity, Stephen Hensel, published in 2003 the results of a meta-analysis of 6 studies on the safety and efficacy of using partial meal replacement used as part of a low-calorie diet, finding actually significantly greater weight loss at 3 months and 1 year compared to a conventional reduced-calorie diet. And these results were very compelling and supported the use of this intervention to safely and effectively produce sustainable weight loss and improve weight-related risk factors. A more recent analysis by Rothbery and her colleagues searched the literature for randomized controlled clinical trials in adults with a BMI over 25, comparing the use of meal replacements daily with comparator interventions. And 13 years later, they found 17 studies reporting weight loss at 1 year or longer. And overall, almost 3,600 patients were randomized to meal replacement and 3,200 to a comparator intervention, which was usually dietary advice alone or support programs alone. But the participants in the meal replacement groups lost significantly more weight at 1 and 4 years compared to the comparative interventions. There was clinical equipoise in the 2-year studies, but that was because those 2-year interventions were not paired with a behavioral component, so that the odds of achieving clinically meaningful weight loss were significantly greater in the majority of the MR interventions versus comparator interventions. So why use total meal replacement? Well, there are many advantages of using them. In fact, they usually improve the quality of nutrition for most of our patients suffering from obesity, because many of them are eating a poor quality, high-fat, high-carbohydrate diet. And as many of you know, these are low in carbohydrate and fat and relatively high in protein, which is the most sating of all macronutrients. They are convenient and portion controlled, and therefore removes the work of estimating portion sizes and calories. In fact, removes a lot of the decision making around meal planning and encourages structured eating. They are widely available and easy to self-monitor. And in addition, you can basically only achieve a significant caloric restriction, such as 800 kilocalories per day, when you have complete vitamins, minerals, and macronutrients with TMR or meal replacement products. This is very difficult to achieve with food-based diets alone. So at least in the United States, the cost per day, depending on product, are about $14 per day. And I will just say that I have 2 teenage children, and they eat food from these 2 establishments, Noodles and Company and Chipotle on the far right. A single meal there is about $11. So this turns out to be cost savings, or at least a cost wash for many. And in fact, in the United States, and the average American spends $21 per day on food, according to the U.S. Bureau of Labor Statistics Consumer Expenditure Survey. So I now want to turn and talk about this pivotal trial called the Effectiveness of a Total Meal Replacement Program on Weight Loss, and I will be discussing the results from this study. So the goal was to determine if TMR was more effective than a food-based diet, and this food-based diet was modeled on the Diabetes Prevention Program diet when they were paired with comparable behavioral intervention. And we looked at weight loss at 26 and 52 weeks. The hypotheses were that TMR would produce greater weight loss than the food-based diet at both those time points. and that there would be a greater proportion of people who would lose clinically significant weight with TMR than with the food-based intervention. This was an open-label, multi-center, randomized controlled clinical trial delivered at 9 U.S. sites. These were both academic centers and freestanding clinics, and they ranged from Alaska to North Carolina, for example. To be eligible, you had to be between 18 and 70 years old with a body mass index between 30 and 55 kilograms per meter squared and be non-smoking. Exclusion criteria included recent weight loss or previous bariatric surgery and organ failure, type 1 diabetes or poorly controlled type 2 diabetes with a hemoglobin A1C in excess of 10%, a cardiovascular disease event or mental health hospitalization within the preceding 6 months, or poorly controlled depression or disordered eating. So the population reflected a typical U.S. patient seeking medical weight loss treatment. That is, there were a higher proportion of women. They were largely middle-aged, white, and actually educated. Here I'm showing you the baseline characteristics. There was no difference between the groups. 52% had prediabetes or diabetes, 33% were being treated for hypertension, and 20% for dyslipidemia. But unusual was that 40% of the patient population had a BMI of at least 40, so they had severe obesity, and these patients would have been eligible to have bariatric surgery. This, of course, was associated with comorbidities, and many of the patients had significant number of prior weight loss attempts, on average 6.2. So here I'm just showing you the interventions for both study groups. The first 26 weeks of the study was considered the active weight loss phase, with the remaining 26 weeks the weight maintenance phase. For the TMR group, the first 12 to 6 weeks did consist of total meal replacement based upon the participant's body mass index. And after 12 to 16 weeks, participants were then gradually transitioned to conventional food, but encouraged to continue to incorporate 1 to 2 meal replacement products per day to achieve weight maintenance. The food-based group followed a reduced energy meal plan based upon estimated energy expenditure. Individual meal plans were developed with participants and the registered dietitian. Both groups were encouraged to increase their physical activity to 100 to 180 minutes per week, and they also received behavioral counseling in weekly group sessions and individual sessions. So there were two co-primary outcomes, that is the percent weight change at both 26 weeks after the active phase and 52 weeks. And there were a lot of secondary outcomes and even tertiary and exploratory outcomes, including the percentage of participants losing 5 and 10% of initial body weight, body composition, and glycemic outcomes. And of course, we assessed adverse events and safety. So as you can see from this consort diagram, 330 eligible patients were confirmed to participate, and 83% had at least one follow-up visit and were assessed in a modified intent to treat population. So let's talk about some key benefits areas related to TMR. So here is the primary outcome. This is the percent weight change from baseline, which was greater at 26 weeks here on the left, dark blue being TMR, light blue being the food-based group, and again at 52 weeks with the group having a 10.5% weight loss compared to only 5.5% at 52 weeks, nearly a 5% difference or doubling. At all time points, absolute weight loss was greater in the TMR group. And of course, there was a modest weight gain, but this would be expected when going from a very low calorie diet to more calories. There was also a greater likelihood of achieving clinically significant weight loss in the TMR versus food-based diet. And I just want to draw your attention to this 10% or more. 55% of the TMR group versus only 23% in the food-based group achieved a 10% or higher weight reduction. And this was still very durable at 52 weeks, again, a near doubling of the effect in the food-based group. Well, what about changes in total fat and total lean mass? As you can see, there was a marked reduction in total fat mass at almost 10 kilograms compared to about 3.5 kilograms for those in the food-based diet. And I will just say the proportion of weight loss from lean mass was similar at 52 weeks, 23% in the TMR group versus 25.5% for the food-based group. And there were no statistically or clinically meaningful differences in bone density. There were a number of adverse events, but these were mild usually, and these consisted of these top-ranking adverse events shown here in this table: constipation, headache, dizziness, nasopharyngitis, some nausea, and diarrhea. Overall, 76.8% versus 62.7% of the TMR versus food-based groups, respectively, reported the adverse events to be mild and moderate. Serious adverse events were reported in 4.5% in the TMR group and 3.3% in the food-based group, but none of these serious adverse events were considered related to the OptiFast product. So what about non-responders? Because this is an important group to consider. Non-responders were defined as participants who lost less than 3% of initial body weight. And at week 26, 15% or a little bit closer to 16% of the TMR participants were non-responders versus 39% of the food-based participants. And at week 52, 24% of the TMR participants were non-responders compared to almost 44% of the food-based participants. So in conclusion, participants in the TMR intervention lost 12.4% of their initial body weight at week 26 and maintained a weight loss of 10.5% of their initial weight at 52 weeks, representing, again, a near doubling of the effect on body weight seen with the food-based group. There was also greater responsiveness to TMR than the food-based diet and lifestyle intervention, with a higher percentage of patients losing clinically meaningful amounts of weight. Although I did not discuss this because I'm going to leave this for another discussion from another study, TMR had greater impact on glycemic outcomes than the food-based diet and lifestyle intervention. The discontinuation and adverse event rates were comparable between the groups, suggesting good acceptability of TMR. So I hope you find that this study provides compelling evidence to support the use of TMR as an effective treatment for obesity. So I now want to turn and talk about a case. This is DM. This is actually coincidental that his initials also stand for diabetes mellitus. He's a 65-year-old with severe obesity with a BMI of 42. His obesity is complicated by hypertension, severe obstructive sleep apnea, for which he wears CPAP, osteoarthritis, prostate cancer, urinary incontinence related to his prostate cancer, long-standing depression and anxiety, gastroesophageal reflux disease, and metabolic syndrome. And when we see a patient, of course, we take a weight history, and as you can see, was about 150 pounds at the end of high school and college, but gradually gained weight in college, largely due to eating a lot of pizza, late nights, and drinking beer with his buddies. But he met the woman of his dreams, and just prior to his wedding, got serious about lifestyle modifications and lost weight. However, shortly after his wedding, he entered graduate school. This was largely sedentary. He was studying all the time and very stressed, and eating a lot of high-calorie foods. And as you can see, his weight escalated to 215 pounds. But after getting his PhD in chemistry, he then got serious again and worked with a dietitian on lifestyle modification, started a running program and lost some weight, but then started his career as a chemist, again, a highly stressful and sedentary job where he ate out of stress, ate out of boredom, had some disinhibited eating, and gained a lot of weight, at which time I saw him. This was his medication profile. This is actually atypical because most of the patients whom I see are on 13 or more medications. As you can see, he was taking a daily aspirin, a combination antihypertensive, non-sedating antihistamine, anxiolytic, antidepressant, 2 bladder drugs, and a proton pump inhibitor for his reflux. Here were his physical exam findings. Again, his BMI was 42, and you can see that just he had gained weight from even 2 preceding encounters to our health system. His physical exam was consistent with common obesity, so he had no stigmata of Cushing's disease or other endocrine abnormalities. So these were his labs at baseline. He had a fasting plasma glucose, hemoglobin A1C, and an oral glucose tolerance test, all consistent with type 2 diabetes. And this is new onset type 2 diabetes because heretofore he had not been diagnosed. And he had a lipid panel that showed elevated triglycerides and a low HDL for a higher risk ratio. So he initiated TMR for 12 weeks, after which he gradually transitioned from TMR to partial meal replacement, incorporating 3 shakes and 1 low-calorie meal over 2 weeks, followed subsequently by 1 to 2 meal replacements and 2 low-calorie meals over 2 weeks, followed by a meal plan designed based upon the MyPlate concept. He also started walking for 30 to 60 minutes during the first 12 weeks, followed by 60 minutes of walking or jogging even on 5 days per week. And here is his weight graph. So our program is 2 years, and as you can see, he had a robust weight loss during the first 12 weeks that was extended to the 6 months, and then maintained his reduced weight out at 2 years. I actually saw him yesterday. He's now actually 7 years post the initial time frame, and his BMI is still in weight still the same. So here is he on the left prior to our program, and this is he on the right. And as you can see, it went from a BMI of 42 to a BMI of 23. More compelling, perhaps, here were his labs and medications at baseline on the left, and here are his labs now on the right. As you can see, his fasting glucose, hemoglobin A1C, and oral glucose tolerance test show complete normalization. He no longer carries the diagnosis of diabetes, and his lipid profile vastly improved. Just look at his HDL, that was increased by 47%, with a 37% reduction in LDL and a cholesterol HDL ratio of only 1.9. And he's no longer taking any of the medications except for this bladder drug, tamsulosin. So let's now talk about some glycemic improvements. This was a seminal trial published in The Lancet entitled The Primary Care-Led Weight Management for Remission of Type 2 Diabetes, that's such a mouthful, or the DIRECT trial. And this trial was to determine whether an intensive weight management within routine primary care would achieve remission of type 2 diabetes. Again, this was an open label cluster randomized trial in general practice clinics. There were 49 centers in Northern England and Scotland. They were stratified by sex and practice size. The intervention was a structured intensive weight loss program delivered by a nurse or dietitian that included total diet meal replacement for 3 months, followed by reintroduction of food, the control group being usual diabetes care. What was interesting about this group was their baseline characteristics, because 59% of the patient participants were actually male. They had a slightly lower average BMI than the BMI to my program or in the OptiFast, but nevertheless, they suffered from mild to moderate obesity. Age was again middle age. They had duration of diabetes for at least 3 years. But you can see that 3/4 of the patient population, both in the intervention and the control group, were taking diabetes medications at enrollment. Here I'm showing you on the right the percentage achieving diabetes remission at 1 year, which was 46% in the intervention group versus 4% in the control group, and still very durable at 24 months or 2 years at 36% achieving remission compared to 3%. These were, of course, very clinically meaningful for those patient participants and statistically significant. So here on the left, I'm just showing you a graph. This is the cumulative, so both cohorts, but this just goes to show you that the more weight loss achieved, the more likely one is to have remission of type 2 diabetes. And again, I'll just call your attention to this 10 to 15 kilogram weight loss, which really translates to about a 10% weight reduction. You can see that at 24 months, 60% of patients were achieving a remission. On the right, I'm showing you the percentage on diabetes medications. Again, initially and at follow-up. In the TMR group, only 40% at 2 years were taking diabetes medications compared to the control group where they saw a worsening and an increase in those taking diabetes medications at 84% of that patient population. So let's now turn and talk about other comorbid conditions that might be helped with TMR. So on the left, I'm showing you a study by Bischoff and his colleagues. He looked at 152 patients in an observational study for 52 weeks, of which for the first 12 weeks, again, were TMR, and they assessed liver fat, inflammation, steatosis, and fibrosis. This was the proportion of those having steatosis and fibrosis at baseline, at 26 weeks, and then at 52 weeks, a marked reduction in those who still had any degree of steatosis. On the right is a study by Vogt et al. In which he took 29 obese subjects. They underwent a 16-week dietary program on VLCD for 6 weeks, followed by gradual reintroduction of food. And they underwent MRI of the abdomen to assess liver fat content. The median BMI decreased significantly from 34 kilograms to just under 30 kilograms at 15 weeks. Liver fat content, I will tell you, was completely normalized from 14.2% to 4.1%. So what about other cardiovascular risk factors? Well, this was just a retrospective review of MR on 153 patients at 4 US sites who were taking Optifast. And you can see that there were, again, clinically meaningful and statistically significant findings for improvements in systolic and diastolic blood pressure and total cholesterol, LDL cholesterol, and triglycerides. So although Ms. Hedy is going to talk about this, we do use this in conjunction, I'm sure all of you do this, with bariatric surgery because it does reduce fatty liver and decreases liver volume. If employed for 2 to 12 weeks of treatment, it also contributes to reducing the difficulty of surgery, helps stabilize comorbid conditions prior to surgery. And we do know that losing at least 8% of body weight prior to surgery leads to reductions in length of stay and increased weight loss post-surgery. We also use it post-surgery to support continued weight loss and help maintain behavior changes. So it might, though, serve as a replacement for bariatric surgery. I don't want to take any, I don't want the surgeons to put a target on my back, but this was a study by Clifton Jackness and from Judy Corner's lab at Columbia University in the United States, in which they looked at people who were going to incorporate very low calorie diet versus undergo Roux-en-Y gastric bypass, and they studied insulin sensitivity and beta cell function in those with the diagnosis of type 2 diabetes. This was a very well-matched cohort. They were middle-aged again with a similar body weight and body mass indexes, a duration of diabetes, which was 6 years, and a suboptimal hemoglobin A1C of 8.2%. And they saw absolutely no difference in the time to achieve, that is 21 days, to achieve a similar weight loss, which was about on average 7.6%, and no differences with the exception of fasting insulin concentrations in any of the glucostatic parameters that were assessed, including glucose, fructosamine, HOMA-IR, and insulin secretion. And what I'm not showing you is there were absolutely no differences in improvement seen in the lipid profiles or in the hunger and satiety scales. So lastly, I want to talk about some provocative new findings. So in the US, I'm sure you are aware that we have an opioid epidemic, but this has been largely overshadowed by the COVID epidemic. Nevertheless, the National Health Interview Survey from about a decade ago found that 19% of Americans report persistent pain, and obesity increases that risk by 60%. Obesity also exacerbates symptoms when chronic pain is already present. So for example, on those diagnosed with fibromyalgia, overweight obesity is associated with worse sleep, greater fatigue, and more sensitivity to palpation. And we have long endorsed this classic view of pain and obesity. That is that excess adiposity increases mechanical load and inflammation in weight-bearing joints. However, I think we need to embrace this alternate view, that is that obesity is an inherently inflammatory disease. I think we have been learning a lot about that just in terms of the COVID pandemic. So we know that adipose tissue is a really active endocrine organ and releases pro-inflammatory cytokines, and that monocytes take on a pro-inflammatory phenotype in adipose tissue, and then these cytokines go on and sensitize the central nervous system. So we looked at 123 obese participants with an average BMI, again, of 40 kilograms per meter squared. 2/3 of the group was female, who endorsed pain in at least one body site at the time of study entry. And we measured pain at baseline and after weight loss using this 2011 fibromyalgia survey criteria. 31 patients also gave us blood before and after the intervention for analysis of inflammatory markers, including IL-6, 10, 1-beta, TNF-alpha, and interferon gamma. The weight loss on average was 16%. 95% lost at least 5% and 80% lost at least 10%. And here I'm just showing you two diagrams or cartoons. On the left is those who lost 10% or more of their weight compared to those who lost less than 10%, who were actually the minority of the group. Here on the right is the legend, red showing worsening of pain, white no change, and blue improvement. And these bubbles down here are the percent endorsing pain at baseline. And as you can see on the left, for those who lost 10% or more, they had vast improvements in their pain scores. And still, although those who lost less than 10%, they still had some improvement. Also, depression scores changed. There was very little worsening and marked improvement with an average reduction in depression of 33%. Fatigue also improved with far more improving compared to worsening with an average reduction of 15%. So I now want to end with talking about meal replacements for long-term weight loss. This was a study done many years ago in which they randomized people to a conventional low-calorie meal-based program or a meal replacement program incorporating 2 meals and 2 snacks per day or replacing them with meal replacements. And as you can see from the get-go in phase 1, the meal replacement group lost significantly greater weight. In phase 2, the conventional food group actually crossed over to replace 1 meal and 1 snack per day, and the meal replacement group actually continued to replace 1 meal and 1 snack per day. And the conventional food group did lose some initial weight, and both groups were able to maintain their reduced weight while maintaining or controlling calories with using meal replacement. But as you can see, that initial weight loss proved to be better than the conventional food-based group. So lastly, I just want to show you some of the evidence-based beneficial outcomes. We know that TMR and VLCD reduce the risk of developing type 2 diabetes in adults with obesity who are at risk for type 2 diabetes and can lead to diabetes remission and improvement. It does improve cardiovascular risk factors and outcomes. And when used before bariatric surgery, reduces postoperative complication rates when compared with no preoperative diet, and is effective at reducing liver volume. It's shown to improve or even reverse NAFLD and may help to avoid, as I said earlier, elective surgery. What I didn't talk about today is that it leads to improvement in some pulmonary conditions such as sleep apnea and COPD. It also has been shown to improve health-related quality of life and mental health. My group has shown that it improves fertility outcomes, and our group has also shown that it improves pain syndromes. So I'll finish there and send it back to our moderators. Thank you very much for all your attention.
Can you hear me? Is it better? Okay. I need to repeat that. Thank you once again, Dr. Rothbery, for the very comprehensive and informative talk on the use of VLCD in diabetes remission and obesity management. Once again, good evening to everyone who took the evening off to attend this session. My name is Verena. I'm representing Singapore Nutrition and Dietetics Association, SNDA for short. Next slide, please. And I'm very privileged to have for today Ms. Hedy Cheng to give us a talk on the use of VLCD in weight management and bariatric patients. Just a little bit about Ms. Hedy. She is a senior dietitian at the Khoo Teck Puat Hospital in Singapore, and she's the dietitian in charge of the integrated care for obesity and diabetes in the hospital. She has graduated from Griffith University with a master's in nutrition and dietetics, and prior to that she graduated from the Chinese University of Hong Kong with a bachelor in nutrition and dietetics. She's also accredited practicing dietitian in Australia, as well as being accredited dietitian with SNDA. Without much further ado, I'll hand over the time to Hedy, who will bring us her topic for today. Hedy, please.
I hope everyone can hear me. All right, just give me 1 second. Good evening, everyone. Thank you for having me tonight, and thank you, Dr. Farina, for the kind introduction, and thank you, Dr. Amy Robert, for the very insightful talk. Before I start, I would just like to declare that I have no financial disclosure or conflict of interest with the presented materials today, and I'm invited by SNDA as a speaker. So in the next 30 minutes or so, I'll be sharing on how do we apply VLCD in our clinic for obesity management, as well as the role of dietitians in VLCD, and also how do we help our patients to maintain their weight after VLCD. But first of all, I would like to share a bit more about my workplace. So I work in a clinic called Integrated Care for Obesity and Diabetes. So it's a one-stop center to help our patients to manage their weight. So we offer weight management, medical weight management programs. So for suitable candidate, we offer weight loss medication and meal replacement. We also offer surgical interventions for such suitable candidate as well. But I'm sure you all would agree is that all weight management treatment options need the foundation of lifestyle changes. And this is why we have a multidisciplinary team, including surgeons, physicians, endocrinologists, psychologists, dietitians, physiotherapists, and nurses. And the picture here is our lovely team. Just now, Dr. Amy Robert has already explained what is VLCD, so I'm not going to spend too much time on this. Basically, it's diets that provides 800 calories per day or less, with enough protein, vitamins, minerals, and trace elements for safe and effective weight loss. Typically, it's composed of 3 to 4 portions of scientifically formulated food products. And the VLCD periods range between 1 to 20 weeks in studies. It comes in, most of the time it comes in powder form that we can make into shakes or soups, but it also comes in bar form as well. As there are more and more VLCD products available in the market, and also the online shopping platform is getting more popular. So I do get asked by patients that if they can take this or that product. So these are the few before that, I will just go through the VLCD mechanism. So first of all is that we replace the meal with a defined portions. So means that with the meal replacement, so then it's easier to control calorie. Secondly, with the energy and carbohydrate restrictions, it will help, means that the fat stores are used for energy through the process of metabolic process called ketosis. Ketones are then produced for an alternative energy sources, and this may help in appetite suppression. And thirdly, the mechanism of VLCD is that it helps to achieve a greater energy deficit, ranging from 1,000 to 2,000 calories compared to about 500 to 700 calories in a conventional weight loss diet. So as I mentioned, there are more and more products out there. So these are the area that I will look at. about meal replacements. So as dietitian, of course, we have to look at the nutrition profile that includes the macronutrients, micronutrients, and also the dietary fiber. Of course, we also look at the ingredients and components of the product. So we have to make sure that they're suitable for some of the patients with dietary restrictions. Are there any potential allergens or ingredients that may cause intolerance? And finally, we also have to make sure that it's safe. So are they recognized by any local or international authorities, or have they been studied for safe weight loss as well? So here are some indications and contraindications. And the criteria here listed is adopted by the clinical treatment protocol by Nestlé Health. So patients with BMI more than 30 or BMI more than 27 with risk factors, for example, hyperpressure, hyperlipidemia, are indicated for VLCD. And of course, patients who need to be motivated and ready to undergo strict supervision and discipline of VLCD. On the left-hand side is the contraindication group, means that these patients are not advised to start VLCD because unlikely VLCD can meet the nutrition requirements, and it might actually make their medical condition worse. And on the right-hand side is the precaution group, means that these patients, we can still consider to start VLCD, but additional care need to be given to ensure adequate nutrition requirements are met, as well as to monitor the medical condition to make sure there's no adverse outcome as well. My majority of my VLCD experience is actually with bariatric patients, and in our clinic we use VLCD for various reasons. Just now, Dr. Amy Rothbery has already mentioned some of them. So first of all is it reduces the visceral fat levels and liver sizes, which lead to reduced surgery technical difficulty. Because when there is an enlarged liver and also a lot of intra-abdomen fats, it can actually mask some of the anatomical markers and increases the complexity of the surgery. On top of that, weight loss has shown to improve pre-existing comorbidities. So with the improvement of comorbidities and the reduction of the liver volume, that can help to reduce the post-operative complication, specifically anastomotic leakage or wound infection. And additionally, VLCD also help to sensitize patients to dietary restriction post-op. So the first 2 weeks after bariatric surgery, patients need to go on a liquid diet. So by having on VLCD before the surgery, it helps them to adapt and tolerate the 2 weeks of liquid diet. In our clinic, the durations of VLCD pre-op range from 2 to 6 weeks based on the individual's BMI, waist circumferences, and surgeon's preferences as well. Now let's look at this study to illustrate the duration of VLCD before operation. So this study aims to investigate the efficacy and acceptability of preoperative weight loss with VLCD. 32 subjects with a mean BMI of 47.3 went on a VLCD for 12 weeks. As you can see, this image is a cross-sectional image of a patient. So the left-hand side is the baseline image, and the right-hand side is after 12 weeks. So there is a reduction of liver volume of 35% and a weight loss of 18 kg. And you can see that there's a lot more space inside the abdomen. When we look at the patient as a pool, the mean liver volume, the visceral and the subcutaneous adipose tissue, and body weight decreased significantly. And the degree of liver volume reduction was directly related to the reduction in relative body weight and the initial liver volume. This study also further did a subgroup examination of 9 patients that had a liver volume more than 2.8 liters, and their MRI image was done at a different time point. So it shows that the total decrease in the liver volume was 28.7%, with 80% of the observed size reduction occur between week 0 and week 2. The mean visceral adipose tissue decreased by 24.1% between week 0 and week 12, and the mean total weight loss was 11.1% between week 0 and week 12. So this study suggests that the minimal duration for preoperative VLCD to be 2 weeks to achieve 80% of the liver size reduction, and the 6 weeks duration can achieve maximal liver volume reduction and significant reduction in the visceral adipose tissue and body weight without compromising compliance and acceptability. Moving away from bariatric patients, we do also offer VLCD for medical weight management patients. However, this group of patients is a bit different from the bariatric patients because they have no change in terms for the GI tract. meaning that for them, after they wean off the VLCD, it will be more challenging for them to control their portion. So this is why for this group of patients, this is more effective when combined with behavioral therapy, active follow-up, and also we may consider pharmacotherapy. One of the important things is for this group of patients, it is important to brief them the whole journey of VLCD and the different transition phases. So patients can start or continue VLCD for up to 12 weeks, which is has shown to be safe and effective for weight loss. Subsequently, then we can transit them into the low-calorie diet phase, which is about 1 to 2 servings of the meal replacement with 1 to 2 healthy meals as well. And then subsequently, we can transit them to the maintenance phase, means with 3 healthy meals with no meal replacement. However, this program and the transition phases need to be individualized. We have to look at how the changes will affect the patient's lifestyle, and also and also depends on the weight goal of the patients as well. So for certain group of patients, it doesn't necessarily mean that we have to start them on VLCD. We can actually also start them on the low-calorie diet phase as well. One common myth that people might think is that when one person loses weight faster, they will likely gain weight faster as well. So is that true? So this study investigates whether the rate of weight loss affects the rate of regain. So 200 participants were randomly assigned into the gradual weight loss or the rapid weight loss program. So it means that phase 1, the patients will be going on this 12 weeks VLCD rapid weight loss, or the other group of patients will be going to this 36-week gradual program with 500 calorie deficit diet. Both groups aim to achieve 15% of weight loss. And after that, when they have achieved 12.5% of weight loss, a weight maintenance diet will be prescribed, and it will be monitored for 144 weeks. So now let's look at the outcome. As you can see on the figure on the right-hand side, the gray area is the initial phase 1, which they have achieved approximately above 15% of weight loss. Then after that, the weight regain was monitored. So at the end of phase 2, the average weight regain was 10.4 kg in the gradual weight loss group and 10.3 kg in the rapid weight loss group. And the weight was not significantly different between the groups after 48 weeks onwards. So this study concludes that the rate of weight loss actually does not affect the proportion of weight regain after 144 weeks. Now let's look at the role of dietitians in VLCD. So we have many different roles and points that we need to cover. So first of all is that before we start, usually our role is that we have to explain the whole journey, which I have mentioned, because it gives a very good guide and motivation for our patients to make behavioral changes. And of course, we have to calculate the nutrition requirements and also educate them on the allowed food and drinks and prescribe a meal plan. We also communicate with teams regarding the medication adjustment and also any blood test that needs to be done. We arrange follow-up and also monitor progress. And of course, we also help to manage side effects or intolerance. Now let's use a case study to illustrate the role of dietitians. So I have got Miss NPS here. She's a 31-year-old female. She was planned for Roux-en-Y gastric bypass on the 12th of October this year. And she needs 4 weeks of VLCD as per surgeon. She's a preschool teacher. She stays with her parents and her mother cooks, and she exercises once a week. For past medical history, she has morbid obesity, OSA, and diabetes was diagnosed 3 years ago. She's on 3 different kinds of diabetes medication, and her BMI is 57.7, and her adjusted body weight is 72 kg. So for patients who are obese, we usually will use the adjusted body weight for the nutrition requirement. And the reason for that is we want to factor in the excess 25% of metabolic active tissue. For the labs result, the vitamin D is low, so it needs to be replaced. And her sugar level, HbA1c was 7.5, and the fasting blood glucose was 9.1. For the diet part, weekdays, she would have 3 meals a day. Most of the time is outside food. And for weekends, it will be down to 2 meals a day and mainly home-cooked food. She doesn't ask for extra portions, she doesn't snack regularly, and she does occasionally have sugary drinks or fast food. So now let's calculate the nutrition requirement for Miss NBS. So for protein, it is important that we need to make sure that we meet the protein requirement in order to avoid any loss of lean tissue. So for her, she needs 72 grams of protein per day based on 1 gram of per kilo of adjusted body weight. The VLCD that we use in our clinic provides about 60 grams of protein, so means that she needs an additional 12 grams of protein. That can be done by adding extra VLCD product. However, the extra carbohydrate and calorie need to be taken into consideration. Well, I personally prefer to add lean protein foods like meat, fish, chicken, eggs because that improves the social aspect of VLCD. And of course, we can also add protein powder. For the fluid-wise, it is important that we make sure patients have enough fluid because VLCD, especially initial stage, it does have a diuretic effect. So for her, the requirement will be about 2.5 to 3.2 liter. VLCD provides approximately 800 ml. So generally, we aim about 2 to 3 liters fluid per day for our patients. That includes coffee or tea with the dash of low-fat milk. Any other minimal calorie or carbohydrate options are also allowed. For the allowed foods and drinks, so vegetables would be an important aspect in this diet. So it gives the extra nutrition, it gives an extra fiber and also the fluid. And again, it helps with the social aspect of the VLCD as well. So we encourage 2 cups or even more of low carbohydrate vegetables. It can be raw or cooked. It helps with compliance and manage social situations as well. For the soup, sauces, condiments, low calorie or carbohydrate options allowed. Usually is consumed with vegetables or salads. For products that are very, very low in fats, we might need to consider 1 teaspoon of vegetable oil to minimize the risk of gallbladder stone formation. After that, we need to communicate with the team for medication adjustment and discuss any medical monitoring that is needed. So these are the medications that we might need to consider to talk to the team. So because when a patient's on VLCD, that might affect the dosage because they improve in sugar level, blood pressure, or even cholesterol level. And also for the drugs that have very narrow therapeutic range, then these are the patients need to be under very tight monitoring as well. So for our case study, Miss NBS, I think the main medication that we need to be adjusted is the diabetes medication. So this was the meal plan that I got from Miss NBS. So basically, it's 3 meals with 3 meal replacements. They gave her 2 extra protein to meet her protein requirement, and also make sure that there are 2 servings of vegetables. Additionally, 1.5 liters. So this diet would be adequate to meet her protein and also fluid intake. So she was also seen by endocrinologists. So it was advised to stop the glycoside, empagliflozin, and also increase metformin 850 mg TDS. She was advised to monitor the BGM at home, TDS at home, and hypo advice was given as well. So 2 weeks later, she was reviewed by dietitian to see the progress. So usually for patients that were on VLCD, we arrange fortnightly follow-up. But before that, she actually was already seen by our endocrine 1 week after the initiation. So she managed to do her sugar level 2 times a day. The doctor was pretty happy about the reading, so the metformin dose was not adjusted. For the weight-wise, she has achieved 4.1 kg of weight loss, and for the diet, she can comply with the 3 packets a day. However, she can only have 1 cup of vegetables only, and the reason is because she's not feeling hungry. So she can, after the shake, she's already very full, and she cannot have more food after. And she can only take 1 liter of water, as she was just not very used to drinking a lot of water. For the tolerance, she had some fatigue and hunger after the first few days after VLCD initiation, but after a few days, 3 to 4 days, she was feeling okay, her energy level was good, and she doesn't feel hungry anymore. However, she does feel constipated. And one more concern that she highlighted to me is that because her mother's birthday is coming up, so she needs to eat outside with family, and she was feeling a bit anxious, and she's not so sure how to go about it. So before I give her another meal plan, let me go through with you. These are the potential side effects that our patients can go through. As I mentioned, most of my patients, the side effects usually come when it's the first few days that the body is still adjusting and the ketosis is not very established. However, we still need to monitor and manage the side effects as we go. So usually we will encourage to start the VLCD on a week or the day before weekends or before off days. So at least then the patient will have time to rest. I also encourage them to stock up low carbohydrate vegetables at home so then they can snack on them when they are hungry. They try to maintain the normal exercise intensity, try to go to bed early or distract themselves from other activities as well. For our Miss NDS, the main side effect is that she was feeling constipated. So that's why, and that attributed from the not enough fiber and the fluid intake. So my main strategy is just to split all her meals into smaller meals. So I put the meal replacement in between meals. So for lunch and dinner, let her focus on the vegetables. So to help her to achieve the 2 servings of vegetables a day. I also encourage her to maybe try to consider cooking vegetables in a soup. So at least that's the additional source of fluid that can help her to achieve her fluid intake as well. For her to handle her social situation, I encourage her to check the restaurant menu beforehand to understand the food options. Also, she can have the meal replacement before she goes out, and when she reach the restaurant, just choose a low carbohydrate vegetables or salad. And if she need to skip a meal, need to skip the meal replacement, then I will encourage her to choose something that with protein or vegetables at the restaurant. But the principle is to avoid anything that has carbohydrate, alcohol, and of course, any sugar sweetened beverages as well. So for Ms. NBS, the surgery was done as planned, and after operation, there was no more medication that patient needs to be on except for some multivitamin. And now the patient is actually week 6 post-op, so she has achieved 15.4 kg of weight loss, 7 centimeter of waist circumference of reduction, and also a reduction of HbA1c 1.2%, and also 2.7 reduction for the fasting blood glucose. Now the next segment is looking at how do we help our patients to maintain the weight after VLCD. As we all know, the nature of the body doesn't allow us to maintain our weight loss so easily, and that's because all the biological responses after weight loss. And when there is energy restriction and weight loss, there is a response in our body that there will be increased hunger because of the change in the circulating hormone. For example, increase in ghrelin and reduction in leptin. So there will be increase in food cravings, as well as there's a reduction in energy expenditure because of the change in hormones, body composition, and even neural activity. So how do we help to increase the probability to maintain the weight is to try to close the energy gap. So we try to control the hunger by increasing the dietary protein, increasing dietary fiber, try to choose food that is low in glycemic load and low in energy density. At the same time, we have to encourage patients to increase their energy expenditure by exercising, and as well as try to do exercise that helps to preserve muscle mass to maintain the metabolic rate. For strategies, first of all, we can consider using meal replacement, 1 to 2 products a day, or VLCD intermittently. So this one later I will explain a bit more. Of course, we can consider use of pharmacotherapy, for example, Sonical or GLP-1 inhibitor. Adequate protein intake and physical activity, I'm sure this one we will all be very familiar with. The speed of food reintroduction after VLCD is also believed to be an important driver. And of course, the use of behavioral changes such as self-monitoring and also planning ahead helps with weight maintenance as well. Now let's look at the speed of food introduction after VLCD. So this study tried to test the effect of the refeeding duration on weight maintenance after successful VLCD-induced weight loss. So 269 patients started a VLCD phase of the study for 12 weeks. So after they have achieved the 10% weight loss, the 169 participants were then randomized into group 1, which is the 1-week refeeding, meaning that the patients will reintroduce one meal every 3 to 4 days, or they're randomized into a group 6, means it's a 6 weeks refeeding, means patients will have, the meal was reintroduced every 3 weeks, and it was followed with an additional 40 weeks. So as you can see on the graph, the top line would be with the white marks is the 1 week refeeding, and then the bottom line is the 6 weeks refeeding. So between week 12 and 52 weeks, completers in the group 6 regained significantly less weight, 3.9%, as compared to group 1, 8.2%. And the overall weight loss at the week 52 compared to baseline was significantly greater in group 6 than in group 1. So what it's trying to say is that the longer refeeding duration after successful weight loss with VLCD actually improves weight maintenance in a 1-year perspective. And also, apart from looking at the speed also, let's look at how we can use meal replacement to help patients to maintain their weight as well. So this study is a long-term 3-year clinical trial trying to compare the clinical efficacy and the safety profiles of 2 active weight loss maintenance interventions. So a total of 153 participants were recruited, and participants were randomly assigned into 2 groups. The intermittent treatment group with VLCD for 5 weeks every 4 months for 3 years, means that patients in 3 years' time, they go for VLCD 9 times, and each time is about 5 weeks. And the regular group, they would have daily meal replacement 1 to 2 meals for 3 years. But before they enter this study, actually all these patients has already completed the 64 weeks of lifestyle intervention, and they have already achieved weight loss. So now we're looking at how the 2 groups maintain their weight. As you can see, now the total of 53 and 56 participants completed. So the weight increased by 0.68 kg and 1.75 kg in the intermittent group and the regular group, and there was no significant difference. One thing that this study highlighted is that the amplitude of weight changes in the intermittent group is 2 to 2.5 kg, which is about 3%, which is lower than the weight cycling definition in a lot of literature, which is about 5%. And there was no difference in all the cardiovascular markers between the intermittent group and the regular group as well. So means this study concludes that only minor weight regain over 3 years, and therefore support the application of long-term meal replacement use with the comparable efficacy and safety of regular and intermittent strategies. Now, last but not least, I just want to share this pilot study that was done in our weight management clinic back in 2016. It shows a different way of incorporating meal replacement to help to manage our patients. So this study was to investigate the effect of intermittent fasting, the 5-2 diet, using meal replacement. The unique features of this study is it was done in an overweight Chinese population in Singapore. And the 2 fasting day of the 5-2 diet, it consists of the 3 packets of OptiFast with protein powder and also multivitamin supplementation to ensure nutrition adequacy. So patients were randomized into the 5-2 diet group or a control group, and the intervention period was 12 weeks. So patients were receiving the same dietary and also physical activity advice. And the outcome is that after 3 months, the intervention group, means the 5-2 diet group, achieved a 4.4% weight loss compared to the control group, which is about 0.6%. And that is significant difference among the 2 groups. And on top of that, the waist, hip circumference, the liver enzymes were also significantly lower in the 5-2 group with no major adverse outcome. So this study concludes that 5-2 intermittent fasting with the use of meal replacement can potentially be effective among the Chinese population in Singapore. So to conclude my presentation today, VLCD is one of the effective tools for weight management, And dietitian's role in VLCD starts from the beginning and it does not end after, but we still have to continue to monitor patients' progress to transit them into the low-calorie diet and also the maintenance phase. We have discussed different strategies that help to apply to help weight maintenance after VLCD. For example, looking at the speed of reintroduction, as well as looking at how we can use VLCD intermittently as a strategy as well. That's the end of my presentation. Thank you very much for the kind attention.
Thank you very much, Ms. Hedy. I'm Baldwin, bariatric surgeon from St. John Hospital. So thank you very much for everyone's, Dr. Rothberg and Ms. Cheng, for your insight into VLCD and its use in obesity management. There were many questions raised by the audience. Perhaps I should direct the first question to Dr. Rothberg. Some of the audience noticed that the biochemical markers in the meal replacement group is significantly different from the normal food-based diet, especially, for example, ALT was raised about 10% of the in the main group. Should we be concerned about this?
Thank you for that question. I don't think so. Many of these people, because of visceral deposition of fat, have NAFLD or steatosis. And I will say on VLCD, there can be a rise as high as 5 times the upper limits of the normal reference range for both ALT and AST, but that does normalize after they are transitioned. And that is probably due to rapid turnover and unloading of liver fat. But no, I mean, the right thing to do is actually lose weight so you can lose visceral fat and therefore normalize those LFTs. They are just the biomarker of the condition.
Thank you very much.
Hi, I've got a question for Ms. Hedy. How do you know from your experience in your practice if the patient is suitable or ready to use VLCD for medical weight loss?
Thank you for the question. So usually when patients express that they are keen, so first of all, we said I would explain to them what is VLCD, what's the cost involved, what are the potential impact that they can have on their lifestyle, and also the whole framework of what's the transition that needs to be done and in order to achieve sustainable weight loss. After that, I will also ask them why it's important for them to lose weight, to make sure that they are not using VLCD for the wrong reason. And also I will ask them what's the level of confidence that they can achieve this, and also try to identify the barriers and the challenges that they have and explain what are the strategies that we can help them. So after all these questions and exploring with patients, then I think we would then come to a conclusion and with the patient that if they are really ready for VLCD. So I guess it's a lot of questioning and exploring and discussion with patients.
Thank you.
There are several questions pertaining to how can we encourage patients adhere to a VLCD complete meal replacement program. Dr. Rothberg, will you be able to share with us any tips on how we can encourage compliance amongst our patients?
Well, I think initially when you're seeing the patient, you have to set some expectations and provide a little bit of hope. I think it's very encouraging when we talk with our patients to share with them that really the initial weight loss, and I'm talking about 2-week weight loss, it really predicts future weight loss. So we know from our group, and we've published on this, that 2-week weight loss predicts 3 months, predicts 6 months, 1 year, and 2 years. So how much they're losing during that first 2 weeks will really dictate how much they've lost in 3 months. And we just say, you know, it's hard culturally. It's a big cultural shift for them to go from what they're doing to now a very socially isolating kind of diet with very reduced energy. But I also share with them that there's nothing more motivating to see the weight reduction that occurs just within the first 2 weeks. For many of our patients, and I did share with you that the average BMI of the individual patient whom I see is 40. So for them to do a slow weight loss can be very disappointing. You know, they're discouraged by 1 to 2 pounds per week, whereas on VLCD, they're you know, rapidly losing weight. And I think if we just kind of bolster that over time, and that this caloric restriction does resolve or improve comorbidities, I think they're willing to do that. I will say that, like Ms. Hedy, I mean, she is obviously very phenomenal at what she does, but I have a cadre of really excellent dietitians who are both armchair therapists and cheerleaders, and provide really great education, messaging, etc. So I'm very fortunate in the position where I work. We also have a social worker, just like Ms. Hedy does. I think they have a psychologist who really addresses some of the other behaviors like emotional eating, disinhibited eating, offers a support system beyond the support system that the patient may have at home or work.
Fantastic. Thank you very much.
So over to Hedy. We've got a question, a very practical question. You mentioned in your talk that you would advise on low carbohydrate vegetables. So the question is, can you share some examples of what are low carbohydrate vegetables?
Sure. Anything that is not root vegetables. Okay, so usually green leafy vegetables, yeah, and tomatoes, cucumbers, all this. Yeah.
Thank you.
Following on to your discussion, Dr. Rothbery, the dramatic weight loss in the first 2 weeks, one of the audiences concerned, do we have to monitor the patients particularly closely? For example, do they suffer from hypoglycemia in the first few days after initiating a VLCD diet?
Yes, you do, particularly people who are on hypoglycemic agents. So I will say from the get-go, if people are on insulin, let's say, for example, we take, and well controlled, we have them reduce their total daily dose by 50%. I noticed that Ms. Hedy's patient example was on sulfonylurea. On day 1, we discontinue sulfonylurea so that they don't. We will tolerate for the first 2 weeks a blood sugar in the 200s because we know that it will rapidly come down. And the last thing we want to do is cause hypoglycemia because it's counterproductive to weight loss. Obviously, they're going to have to eat in order to raise their blood sugar. So metformin is not a hypoglycemic. It's an anti-diabetic, of course. So we keep people on metformin just for other reasons. But anything that is a hypoglycemic, we must adjust. And as Ms. Hedy also said, we adjust antihypertensives. We're very cued in if they're on Coumadin or warfarin. You know, that has to be monitored every 3 days until they have a stable INR while on VLCD. So yes, thank you for that question. It is imperative upon the physician really to closely monitor that patient so he or she does not get into trouble.
Fantastic, thanks.
So the next question for Hedy is that you mentioned the use of partial meal replacement during the maintenance phase post-bariatric surgery. So can you share with us for how long would you use the partial meal replacement for?
Thank you for the question. So I think I mentioned about using partial meal replacement as more as the weight loss or weight maintenance strategy. So the evidence has shown that we can use it for long term, and actually for certain patients they can actually stay at the low calorie diet with meal replacement as a weight maintenance strategy as well. So it means that in short is that partial meal replacement, there is no timeline to it yet.
Thank you.
We've got a next question for Dr. Rothberg. What are your views on the use of anti-obesity pharmacotherapy such as phentermine or liraglutide as an adjunct to improve compliance and acceptability to VLCD?
So I'm all for it. I will say I'm not a big lover of phentermine for a number of reasons. I don't know about in Singapore, it is a controlled substance in our country. And phentermine is only approved for short-term use. It does rev up metabolism a little bit so that when you stop taking it, you're right back to baseline. That might cause a challenge, but I am very much in favor of the GLP-1s. There was a recent study published using liraglutide, or maybe it was semaglutide, along with intensive behavioral therapy dietary intervention. It wasn't VLCD. That study has not been done, but there's no reason to think that it couldn't be used as an adjunct. We in our program actually don't use it in the initial intensive phase of VLCD. We find that people are not hungry on VLCD and really don't need it, but we do use it when they're having an uptick in weight. And as Ms. Hedy shared with you a study looking at all the counter-regulatory responses that happen in a weight-reduced state. So as soon as we see an uptick or patients are experiencing greater hunger and cravings, we have no difficulty adding on pharmacologic therapy. It may not be always a GLP-1. In our country, we have a multitude of insurance companies that we have to deal with. Some will cover weight loss drugs, others will not. So we have to sort of finagle what we're going to use and what's allowed per the insurance carrier. But thank you very much. Yeah, I appreciate that.
Fantastic. Thank you.
So over to Hedy. The next question is, how do you advise a patient if they experience side effects like fatigue, hunger, irritability for the first 3 days when they start on VLCD before ketosis kicks in? How often and how would you be in contact with the patient after the start of VLCD?
So for our patients, we touch base with them for VLCD initiation would be fortnightly. But before we start VLCD, usually we would already preempt then that these are the potential and common side effects that you might experience in the first few days. So I usually tell them, try to, like what I've mentioned, maintain the same physical activity level, make sure drink plenty of water, stay hydrated, get enough rest and also make sure you stock up the low carbohydrate vegetables to get prepared for that stage. Yes.
Thank you.
Thanks. Well, perhaps I should ask a personal question. In my bariatric practice, there are a certain group of patients who don't really lose weight at 3 months after surgery. Do you have any advice, Dr. Rothberg, on the use of VLCD in this group of patients?
Yes, we do try to do that, Dr. Young. I mean, I think many of them feel so discouraged if they're not losing weight after surgery that it is a hard sell, but we do encourage that. We'll pull out all the stops. We'll do VLCD. We will also adjuncts if we can, and obviously we try to figure out what are their barriers to really reducing their calories. And so a lot of the time we are referring to our but in terms of our intervention, yes, VLCD or partial meal replacement if they're willing to do that, and pharmacotherapy.
Thank you very much for the questions and your active participation, but in the interest of time, we'll have to bring the Q&A session to a close. So together with my co-chairs, Dr. Yong and Dr. Tan, we'd like to thank Dr. Amy Rothberg and Ms. Hedy Cheng again for the excellent talks. We also like to acknowledge and thank Nestle Health Science for hosting this webinar. We hope that you have gathered some useful insights on VLCD that can help in your practice. A recorded webinar will be sent to your email along with a certificate of participation, Do share your feedback or any questions that we didn't manage to answer via the survey link that will follow shortly. So we've come to the end of the webinar. On behalf of SASO, SNDA, and OMSSS, thanks again for joining us tonight, and we'll see you next time. Good night.